no other definite explanation for the VTE, then we would want to do genetic testing. Also, if there's an unexplained recurrent DVT of pulmonary embolism, then we would want to know why, and genetic testing could let us know. So, a pulmonary embolism is, like we said earlier, when a deep vein thrombosis breaks free from its original site and it moves to the lungs. And this can be life-threatening. It can cause sudden breathing difficulties, chest pain, and you can even cough up blood. Factor V Leiden mutation increases the risk that clots will break away from their original site and travel through the bloodstream. And this alone increases your risk for a pulmonary embolism. But only about 10% of individuals with the factor V Leiden mutation ever develop abnormal clots. Some suggestive findings are a history of one or recurrent venous thromboembolisms that manifest as deep vein thrombosis or pulmonary embolism, especially at a young age or in the absence of a strong risk factor for VTE. Lab findings such as low activated protein C resistance on an APC resistance qualitative and quantitative assay. If you have a family history of a first-degree relative with one or more VTE events that is consistent with autosomal dominant inheritance, which affects males and females in multiple generations. Further diagnostic testing includes coagulation screening tests, which is the most cost-effective, but it does give misleading and false normal results, especially in individuals on therapy with thrombin inhibitors or factor XA inhibitors, as well as in the presence of lupus anticoagulants. So this is not a reliable testing option. Next, you would want to do mutation testing, which you can use polymerase chain reaction methods to detect factor V Leiden mutation. You are given a detailed analysis of that specific segment of DNA, and the DNA from the individuals without the mutation would be cut by the restriction enzyme, but it would not cut the DNA in patients with the mutation, which will result in different banding patterns on the gel.
PCR testing is a much more preferred testing options because of the quick turnaround time. You can get results in a couple of hours rather than waiting a couple of weeks for a DNA analysis result.
And finally, genetic testing. You can do a targeted gene analysis, which will look specifically for the F5 gene.
Genetic testing is done to confirm your diagnosis for this mutation.
If you have a family history of factor V Leiden, or members of your family are thrombophilic, or you're a patient of antiphospholipid syndrome, or you need to be on an anticoagulant, then you would want to get genetic testing right away. And if you are positive for a functional assay for APC resistance, then you should also get genetic testing done to confirm your diagnosis. And as far as treatments go, the American Society of Hematology has a pretty clear process for treating these hematology conditions. Your initial management is determined at your diagnosis of the DVT or the pulmonary embolism, and that is when they use thrombolytic therapies, and these determine the initial anticoagulant therapy that you will be on for a few days after your diagnosis. And for patients with DVT and or pulmonary embolisms, this guideline suggests using direct oral anticoagulants over the vitamin K antagonists. So once your period after your diagnosis passes, then you will begin your primary treatments, which you will continue for about 3 to 6 months. After you complete this primary treatment, then it will be time to either stop the anticoagulant or continue for secondary preventions. And the secondary prevention is usually continued indefinitely, and these patients should be reevaluated on a regular basis to review the benefits and risks of continued anticoagulant therapies. In summary, there is a strong recommendation for the use of thrombolytic therapy for patients with pulmonary embolisms and the use of indefinite anticoagulation for patients with recurrent unprovoked VTEs. And as far as next steps, we would offer a referral to a hematologist who will address the blood clotting management and treatment options. And of course, we would want to confirm diagnosis, and the way to do that would be through genetic testing. So we would definitely want to seek either a geneticist or a genetic counselor. And I also would like to share the resources available for people with this condition. There is the Thrombophilia Awareness Project. There are many helpful resources on this site, support groups, as well as research study options available to people with thrombophilia. Next, there's the National Blood Clot Alliance and the American Blood Clot Association. So, same idea. They have great Facebook groups and links to information about support groups all over the country. And they have additional information if you would like to read more about this condition. Please let me know if you have any questions.
I have a question.
Yes.
For genetic testing, how long does it take to get results back? Because I know in the NICU, sometimes when we send stuff, I feel like some stuff can take longer than others, but I don't know if that's actual genetic testing that takes longer
Mhm.
or if it's just the time of like how busy they are.
Okay, that's a great question. So it would take about 2 to 6 weeks. And of course, it depends on the lab and, how busy they are, but it can take a few weeks.
Okay, and it doesn't really depend on the
It,
mutation that you're looking at.
no.
Okay.
Yeah, it wouldn't really depend on what gene you're looking at, especially if the condition is already known. They can do a panel, which is where they look at genes that they already know are related to thrombophilia. And so they can look at multiple genes like that. Or if you're doing a targeted analysis, they can specifically just look at the F5 gene.
Oh, perfect. Okay.
Yeah.
Okay. So with my question would be with the genetic screenings that is suggested here,
Hmm.
would that help guide different ways of treating a pulmonary embolism? based on the source of the thrombophilia, or do you feel like the treatment would ultimately be the same? Like, would there be other options for different genetic variables?
Um, okay, so if I'm understanding you correctly, you want to know pretty much what's the benefit of getting the genetic testing done when you have this condition, right?
Sure, yeah.
Okay. So I guess if you were to know um, that you have this mutation, your treatment wouldn't be different necessarily, but you would know that this is why you're prone to having these, or this is why it's happening. And so I guess you would be more cautious or more aware that it could happen again. But as far as treatments go, there's no treatment specifically for pulmonary embolisms for people with this mutation. So the treatment would be the same.
Great answer. Thank you.
Mhm. All right. Any other questions? No, baby.
I think I have any questions. Do you have any, Danny?
Yeah, I mean, it's just a lot to digest, so
Yeah.
I could just have you reread the whole thing to me, and that would be just one giant question. But you did a great job,
Thank you so much.
especially with the hurdles and the distractions in the room.
Mhm.